IC is going to be on tackling capsular tears head-on video Odyssey. Well, the basic intent today is that we want to make it interactive and we'll stop the videos and I would ask Dr. Tushe that if by any means I'm missing out and if he wants to add a few things, he can add, and anybody for that matter feels that a few queries need to be addressed, I think we have mics in front and we can take the questions as and how we go along. So the concept is that we just want to put across a few innovative ideas which we have and a few techniques which have been strengthened over the time, which I feel should be made very clear to each one of us. So I would like that Dr. Tushe should let the ball rolling. So he would be taking up a few things in the initial stages and as and how the time goes, the next part I would be taking and we would be alternating between each other as and how we go on in the session. Over to Dr. Tushe.
Thank you, Dr. Rohit. I would like to thank AIOS for giving me this opportunity. So, as told by Dr. Rohit, so it should be a interactive instruction course. So everybody is free to ask any questions in between. So I'm gonna start. So it's on. It's already time 9:45. Can you connect my screen? Screen mirroring. Can you switch on हाँ स्क्रीन मिररिंग ऑन कर दोगे इसमें हाँ वीडियोस है ना सेटिंग्स हाँ ये रहा सेटिंग display.
I think in the meantime that he sets it up, I'll start with a very important aspect. Anterior, Dr. Tushe, are you ready?
No, it's screen mirror screen. एक मिनट ये रहा Yeah, now it's fine. Okay. So, good morning everybody. I will be talking on torn rhexis, its prevention and management strategies. So let's understand the radial tears in a capsular rhexis margin is a common complication. It occurs primarily during capsular rhexis or secondarily it can occur during any step in the phacoemulsification. So all of these are predisposing factors like a white intumescent cataract of pseudoexfoliation, weak zonules, shallow interior chambers, high posterior vitreous pressure, pediatric cataracts, fibrotic cataracts. So all these are predisposing factors for an anterior capsular tear. So let's go through this video and understand a basic prevention strategy. So you see in this video, as I start doing my rhexis, suddenly I realize that it is going towards the periphery. So what do I do here? First of all, always inject the interior chamber with viscoelastic to make the iris concave, and then so what I've done is I've injected the viscoelastic in the interior chamber and then always hold the tear as close as possible to the root of the tear, and then you can do a Little's maneuver. Little's maneuver is basically you pull the tear 100° to the line of the tear. So what I'm going to do is 100° to the line of extension of the tear. So I pull it back and it comes back. So this is Little's maneuver. Coming to another case, this is the case where there was a high vitreous pressure, a shallow interior chamber. So I start doing the rhexis, and as I proceed, it is going towards the periphery. So what wrong I have done here is, you can see here what I did. When I injected viscoelastic, I injected in the line of the tear, so it extended further. So if you see here, it has extended further. So what I should have done is, I should have injected the viscoelastic on the other side of the flap so that it could lie flat on the nucleus rather than injecting and making it go towards the periphery. So what I do here, how I manage is, I make a nick on the other side of the capsule and I can complete the rexus. So this is the way this is another way how you can manage the rexus extension. So most important thing in preventing an anterior capsular tear is a good, uniform and consistent anterior capsular staining. So we have published this technique. It's a modified 30 gauge needle trypan blue staining technique. What we do here is, if you see in this video, air is injected from the main port. It is an under air trypan blue staining technique. A 30 gauge needle is used. It is entered through the peripheral cornea, you can see here, and a few drops of trypan blue dye is injected under air. So what are the advantages of this technique is, it is safe, simple, minimal cost, no shallowing of AC is seen, there is no iatrogenic trauma, AC remains stable during the whole time of 15 seconds, and it is a self-sealed entry till the whole time is over, and there is no egress of air throughout. So you have a good uniform capsular staining. And then you can see there's a good uniform capsular staining. So in cases where you have shallow ACD of less than 3 millimeter, what you can do is you can inject 0.05 ml of the syringe, proximal syringe with air, and then followed by trypan blue stain injection. So you can see here it is a shallow chamber. So 0.05 ml proximal is filled with air. So you can see how the chamber is. You can see again what happened here is, in shallow ACs, air is injected before the injection of dye. So you can see how the AC deepens in this. So it is a good technique, excellent interior capsular visualization, absence of dye staining, selective painting, there is minimal usage of dye, and this technique eliminates shortcomings of all the techniques. So let's come to the white intumescent cataract. So you can see here, what we do here is, with the same 30 gauge needle, what I'm going to do is, I'm going to decompress the bag in the central area. So I'm going to make a nick in the center, and at the same time I'm going to aspirate the fluid with the same needle. So I've gone in. So you can see how the fluid is getting aspirated. My main aim here is to decompress the bag in the central portion of the lens. So you know, in white intumescent cataract you have a high intralenticular pressure. So my next step is to make a small rexus in the area of the decompressed part. So that was the center because I aspirated. Now you can see there is an high intralenticular pressure in the mid periphery. So what do I do now? So I take the cannula, I do capsular milking as described by Dr. Chi. So what we do is, we do a gentle massage over the capsule with the cannula from the mid periphery to the center, and you can see how the fluid is coming out. So now I'm reducing the intralenticular pressure in the mid periphery area. So you can see how the fluid is coming out. So this has reduced. Now the next step is to aspirate the fluid, the remaining fluid, and always remember that you have compartmentalization in white cataract. So there is still fluid in the posterior compartment. So with the same cannula, you aspirate and you gently press the nucleus so that the fluid from the posterior compartment also comes out. So once you are sure, now the capsule behaves like a normal capsule. So the next step is, again you can see, I could see the fluid. So I'm doing capsular milking, and you can see the remaining fluid coming out. So now the next step is to make a nick with the vanas, and then you can, and what I want to show here is, like the patient, I was doing it on a topical anesthesia, patient moved and the rexus went towards the periphery. Because it was a normal capsule and there was no intralenticular pressure, what I did here was, how I brought it back was,
you have to say how,
Yeah.
how you place the visco into the interior chamber.
Yeah.
Had you placed it distal, it would have, further made that go to the periphery. So, you know,
So the
putting
injection of visco has always need to be done so that the flap rests on the nucleus. it should lie flat on the nucleus rather than going the other way, because then it will just go towards the periphery. So because there was no interlenticular pressure, I went on and I did a Little's maneuver. So the Little's maneuver is 100-degree to the line of extension of the tear. You have to pull it, hold the capsule as close as possible to the root of the tear, and you can see it just comes. So if there was high interlenticular pressure, it would have just gone towards the periphery.
I think there's another thing which you can, apply. When you are trying to pull it in the Little's maneuver, you should be as close to the anterior capsule.
Yeah.
If you are slightly up, then you have a worse control. But if you are in the same plane, pulling it at 100 degrees,
Yeah.
that creates a better control. So there are three things in it, two things rather. First, what you said. Second, 100 degrees. Third, the way you pull it.
Yeah.
It has to be important, and it has to be in a closed chamber.
Yeah.
The way it's a micro forceps. So there's a chamber stability also, which is very important in such
Yeah,
situations.
so that's why I'm using a micro forceps, and my forceps, they are just floating in the incision. I'm not depressing the incision also.
Yeah,
So that's
absolutely.
another point.
Yeah, absolutely.
So that's how I complete this and manage my anterior capsular tear. So another strategy that you have to follow in pediatric cataract is, as we know that it is very elastic and the chances of going towards the periphery is also there. So trypan blue staining often decreases the elasticity, it makes it rigid. And the other thing that we can do here is that you can try making a small rhexis, and you should do a centripetal maneuvering of the capsule, because there are high chances of an anterior capsular tear in a pediatric cataract. So all these points, if we keep in mind, we can avoid an anterior capsular tear in such cases. So this is one of the cases where I had an anterior capsular tear in flax. As we all know, you get these misfired areas and you get these rips in capsule, so it often leads to an anterior capsular tear. So this was a case where I had done a rhexis with femto. I continued the case. You can see how beautifully it just comes out with a pinch. But while I was doing a cortical aspiration, I suddenly realized that there was an anterior capsular tear. So what should I do here? So I took the advantage of flap motility sign. Flap motility sign is like when you see an anterior capsular tear, the flaps, if they are everted and fluttering, this means it is pre-equatorial. It has not extended beyond equator. So my vision was all on the flap, and you can see how the flap is fluttering. So I reduced my IOP parameters. You can see my IOP is 28 because I don't want any AC fluctuations. Even with the viscoelastic, you can see the motility of the flaps. And I tried seeing the extension. It was up till equator. So, so my plan was to do a slow guided injection of intraocular lens. The haptic should be perpendicular to the line of the tear. It was a toric lens. So luckily, it and I was able to complete the case. So thank you. I will move on to Dr. Rohit for his other demonstrations.
Thank you, Dr. Tushya. So I'll be taking out, despite everything, we have an anterior capsular tear. So let's see, these are the two scenarios which one comes across. First is a rhexis tear, and the second is an Argentinian flag sign. So now the question is, why is this a surgical dilemma? The answer is, at times we can complete phacoemulsification, whereas at other times we end up in a catastrophe. So this is the surgical dilemma. But we have to realize that there's a silver lining in it. And now what is the silver lining? The radial tears do not easily and fast become wraparound tears. Because of thickened mid-periphery of anterior capsule, and there's a barrier which is created by the zonular anterior capsular attachment. So unless you are really rough and you do not follow the basic principle which I will tell, you are going to have a safe sailing. So now what is the surgical plan? First of all, no panic mode. Second, we have to evaluate. Now so there are two steps now. First is we have to evaluate whether it is a pre-equatorial or a wraparound tear. And the second is we have to adopt safe techniques. So now how do we evaluate? We evaluate it by the flap motility sign. And what do we adopt? We adopt safe phacoemulsification techniques. Now let's see what it is. With this, the flap motility sign, that is just to evaluate if it is fluttering the flaps and everted, it means it is pre-equatorial. And if by any means it becomes a wraparound tear, then it is no longer a fluttering flap. It is inverted and non-fluttering. Now let's see, we know all this. Now how do we move about? We have to evaluate it. And how do we evaluate it? Just inject visco. Did you see the flap flutter? Yes, this means that it is pre-equatorial. Any questions, ma'am? Sorry. So this means it is pre-equatorial. Now let's see another case scenario. Visco in, flap. Could you see it evert? So this means it is pre-equatorial. First evaluation done, let's reconfirm. Now how do we reconfirm? Put in the, your phaco handpiece, and you will find, before you really start, just irrigate. And if you find it is fluttering, this means it is pre-equatorial. Let's see another case scenario. Again, phaco handpiece, irrigating in, and it is fluttering. So the first thing first, we know it is pre-equatorial. Now what next? The next part is we have to evaluate the extent of these tears. How do we evaluate? You can do it intermittently, or what we have done in our scenario is, if by any means it happens, your assistants are trained for it, or somebody who is viewing it just to see whether the flap is fluttering or not. Just to evaluate. The flap motility sign doesn't mean that you become free from all the surgical steps which you take. Well, that is just one thing, and that helps us to evaluate whether it is pre-equatorial or a post-equatorial tear. Now, what is the surgical plan? Surgical plan is, first is have stable chamber setting. First step is stable chamber setting, have a calibrated side port incision, because side port incision is usually a stepson. You don't bother about it. There is so much of a flux of fluid from the side port, iris touches, chamber instability, which leads to a situation wherein there is more trauma and there's a predisposition of the flap to extend to the periphery. First is the calibrated incision. So that is very important because it creates. Second is fluidics. So the fluidics, active fluidics. I do not have any financial interest as far as the active fluidics is concerned. But that helps because with a reactionary, a gravitational, it's a reactionary one. With the active century, it is there, fluid control is right in the palm of your hand. The next step, the third part of the whole story is the slow motion phacoemulsification. Bob Osher and our own Abhay Vasavda have been responsible way back in elucidating how slow motion phaco works. With this slow motion phaco, we are going to use low fluidics 20 to 23, which is close to the physiological IOP. So this is the third step. And fourth step, we create a situation that there is minimal pressure difference between the anterior and the posterior segment, by subsequent to which the anterior hyaloid phase doesn't continue to be your foe. It becomes your friend, it becomes your ally. So that is what the basic concept is, the surgical plan is. So let's see, low IOP, slow motion phacoemulsification, I've already talked about. Stable chamber settings. With this low fluidics, slow motion phacoemulsification, we are going to have a stable chamber setting. Site of incision is very important because at times we are not sure. Because if by any means you are in the line of the tear, then it's not a good situation. So, and if by any means you want to create additional rhexis extension, you may as well. No pushing of nucleus while trenching. Avoid wide separational forces in the direction of tear, and supracapsular emulsification. So with high settings, what happens is there is unstable chamber settings, and it creates a situation wherein we have a wraparound tear and all the complications. What happens with the low settings? It's a very friendly situation. The flap motility is helping you. You are using techniques. You are not putting stress to the end point of the flap with unstable chamber setting and creating a situation that it becomes a wraparound tear. So now let's see, these are the IOP settings which I use, 20, which boils down to 27 millimeters of 27 centimeters height. And then, we have that 23 is the flow rate, and this is what it is. Because it has been seen that if your bottle height is more, even with an intact hyaloid phase, even with an intact, posterior capsule, the hyaloid phase breaks, and it has been shown by Vasavda and Dr. Abhay Vasavda and company. This flap motility sign as a sign of posterior capsule rupture has been a published technique whatsoever. So let's see the technique. Let's start. Let's see where the site of incision is. Luckily, the site of incision is not in line with the rhexis tear or the Argentinian flag sign. That is a positive sign. See the fluidics, it is 20 with aspiration rate 20. So now I've gone in. What do I see? The flap is fluttering. I am not pushing. See the direction in which it is being chopped and separated. This direction is very important. It is in the line of the tear. So this doesn't put stress. So the second most important thing is it has to be in the line of the tear. So we move on. Separational movements, I'm leaving it there. Again, separational movements in the line. I'm using Vasavda's technique of multi-level chopping. Slow motion rotation. Because the IOP is 20, you can play around with it. And it's a hard nucleus. I have brought it forward. I'm doing it slowly. Have a look at the flap. It is still fluttering. So this means the maneuvers which you are using, they are not insulting to the end point of, the flap where it is. So you can see how I am continuing. I am doing emulsification. So I am doing it at a slow motion. You will see that, it is coming, it is sticking onto it. And I'll show you how I will use chopper as a shield. I'm continuing with it. Now what is happening with this? There is low infusion pressure. There is no posterior bulging of the posterior capsule. There is low infusion of fluid. There is, and there is less stress to the end point of the flap. All this is happening, and by any means, if the fluid is going behind, that is not, disturbing the anterior hyaloid phase. So this process is continuing, and you will find still that the flap is fluttering. Now, what is this chopper shield? Now, when I am doing this, you have to realize it's a hard cataract. See where I have placed the chopper. I have placed the chopper between the phaco-tip and the cornea. So it is acting as a shield. When it is acting as a shield, it is not allowing the hard nuclear fragments, because I am doing it at a slightly anterior plane. I am not letting it come and hit the endocorneal endothelium. So just see again how I am doing it. The IOP is still 20, stable chamber settings now. IA is being done. You will find that the flap by all means is fluttering here. So the process is continuing, and you will find eventually I am enlarging the IOL is in place, enlarging the rhexis so that I do not have, problems associated with it, intraoperative OCT to see whether the flap is, whether the incision is healed or not.
Another thing that you did in this video was like, because it was a hard cataract, normally what we do is we divide all into 6 to 8 pieces, but what you did strategically, you took out one piece to decompress the bag so that you had a good space to prevent any stress on the bag also.
Yeah.
So that was another thing that.
Yeah, absolutely correct. So that is a small trick which should be added in your strategy. So now the question is, what is the end point for conversion? The flap is fluttering. And we do not know how to go about, and if we have to convert, when do we have to convert? So conversion is, we should know what is the end point of safe phacoemulsification. And when the surgeon is not confident, because I've seen so many surgeons across, but luckily now surgeons across the world are following it. They believe that when there is an anterior capsular tear, just convert. Now let's go into it. Let's see this video. The surgeon, in an effort to enlarge the rhexis, inadvertently created a situation wherein there was an anterior capsular tear. The phacoemulsification was continuing. You will find that the flap is fluttering. Now in the process of dividing, suddenly the flap stopped fluttering. Now what does that mean? It means it is the end point of safe phacoemulsification. Here the surgeon should have converted, but the surgeon was oblivious of the relevance of flap motility sign, continued, and eventually landed up in a situation wherein there was a nucleus drop. So friends, what we need to know is, first, the flap motility sign, safe phacoemulsification techniques, and we should know the end point of safe phacoemulsification. So do not panic, evaluate for the flap motility sign. Would you continue with the next one? Yeah. And end point of safe phacoemulsification, site of IOL implantation is very important. Safe phacoemulsification techniques, stable chamber setting, site of incision, reduction and separation, and specific direction of separational forces, supracapsular emulsification, less rotational forces. Word of caution: it is not one flap which is important. All 4 flaps should be fluttering. If there is you should definitely rule out a pre-existing PCR. I received a call from John Hart, who is in the American Society of Cataract and Refractive Surgery, the chief judge in the film festival. He said, Rohit, there was a pre-existing PCR because the patient was on anti-VEGF. The flap was fluttering, but still, there was a PCR, and I knew this PCR is because there was a pre-existing defect. So friends, we should be sure that the pre-existing PCR should be ruled out. Pre-existing PCR may give false positive pre-equatorial fluttering and everted flaps. Over to Dr. Tushya.
We would like to take questions also in between if we have any. So, do we have any questions till now? Okay, so continuing to the capsular tears. So let's see some of the advancements in PCR management techniques. So this was a case of a phaco punch. So what do you do now? So our fellow, she started the case. She did the sculpting, but inadvertently while doing the sculpting, so you can see she was sculpting, and suddenly she realized that she had reached the last plate and ended up into a phaco punch. So the good thing was that she realized at the right time and she stopped and handed over the case to me. So what I did, first thing was to lower my parameters. So I reduced my parameters, reduced the IOP, reduced the aspiration flow rate, and that's how I started my case. I injected the viscoelastic at the site of punch to tamponade the vitreous, and then my aim here is to do a low IOP phacoemulsification with slow motion phacoemulsification, slowly dividing the nucleus. The advantage of low IOP phacoemulsification, as rightly said by Dr. Rohit, was that there are minimal pressure differences between the interior segment and the posterior segments. So what happens is these nuclear fragments, they float in the interior chamber. Another important thing is that your incision should also be calibrated, because you can't afford a flux from the side ports or the main port incisions, which causes instability in the chamber. So you can see here, there is no undue deepening of the interior chamber. There is no posterior bulging, minimal chances of posterior extension of the PCR, and the other nuclear fragment, the hemisphere, is also taken out. The minimal fluid, minimal pressure or minimal infusion of fluid prevents any vitreous hydration also. So this patient was of a younger age group. There was no peaking of the pupil. So I kept continuing phacoemulsification as I was sure that the hyaloid phase was intact. So that's how the nuclear emulsification was completed. Always remember to inject viscoelastic before taking out to maintain chamber settings. So what I do here is I retract I use coaxial IA. So I retract the sleeve of coaxial IA so that I can have a different level of irrigation and aspiration, and then you have low uh, infusion of fluid, no low AFR, and remember to inject viscoelastic before taking out the probe. The remaining cortical matter was taken out through dry aspiration by Gill's technique, and then three-piece IOL was injected into the sulcus, and luckily the rexus was of a smaller size, so I was able to do an optic capture, and always inject triamcinolone to check for the vitreous.
I think bimanual is some, if you're using bimanual, that's a much, better situation, because there you are able to differentiate the fluid level of fluid and aspiration. But I think by retracting, one can even retract the sleeve more to create a situation wherein you can, have a different plane of irrigation and aspiration.
But another thing which I found with bimanual was because you are making another port which is not calibrated. So I've had a situation where everything went well, but when I used bimanual, there was so much of efflux from the side ports that the chamber went so unstable, and the PCR, which was small, it just extended and went well.
Yeah, Dr. Gaurav Luthra, he has calibrated his side port with a bimanual so that it doesn't cause undue efflux of fluid. So what I personally feel, each one of us, when we go back, should calibrate the side port incisions. It really helps at all stages, whether you're using a bimanual or you're using, a coaxial, that should not make a difference. But the basic concept which is involved is that by all means, there should not be any chamber instability, which should cause all, it starts the Pandora's box of problem. So by all means, side port calibration, whether you are using coaxial, because as of now, we do not have calibration done for our bimanual. So if you can, I think that can be another option.
So
And yeah, and another thing which I would like to state is that, in this, the capsular axis size was slightly bigger. Had it been smaller, we could have done reverse optic also. Because reverse optic is something which can come into force wherein you have a, you have a posterior capsule rupture. You can round it off, and you can, put the IOL. First you put the haptics by just flexing the haptics rather than just pushing them in, and then you can pull the, the optic out. But that should be done only when we are sure that the capsular axis size was slightly smaller, so that the, the optic can hold on into the, to have a reverse optic capture.
So continuing, so you can see the PCR size remained the same at the start and the end of the surgery, and following post-operatively, fundus showed absence of cortex or nuclear piece, and the visual acuity was good. So coming on to posterior polar cataracts with pre-existing PCRs. So we have been doing preoperative OCTs for all our posterior polar cataracts, white intumescent cataract, traumatic, pediatric, if we are able to do in pediatric, all of that, just to see the capsule status prior to the surgery so that you can have a good surgical planning. So in this case, there was a conical morphology, and this has been shown by Dr. Pujari et al. That this indicates a pre-existing PCR. So our what we do is we do an oval rexus as described by Dr. Kiranjeet, where you can take the advantage of both small and large ram axis. Small Rexes gives an advantage of optic capture, nuclear piece retention in the bag, tamponading vitreous, and large arm of Rexes help prevents rise of intraocular pressure. It helps in doing safe end-to-end sculpting, easy division, easy sub-incisional of cortex removal, and smooth IOL entry. So let's move on to this case. So I start, we have been making oval rexes in all our posterior polar cataracts due to the advantages. So here my plan is to do stop and chop technique, and I will do a low IOP phacoemulsification with slow motion phaco. So slow division is done, cross chopping as described by Ronald Yaw. So cross chopping prevents any rotation of the nucleus. So that if you rotate the nucleus and you know there's a pre-existing PCR, it can lead to a drop. So you don't have, remember not to rotate your nucleus. You have to do a slow motion phacoemulsification. And as I told you, you can see the IOP, it is 20 with a low aspiration rate, and the remaining nuclear piece is phacoemulsified. And the advantage of, as I told you, there's a minimal pressure difference between the anterior segment and the posterior segment, so it prevents the pushing back of nucleus. It prevents any undue deepening of anterior chamber. There is no posterior bulging. There are minimal chances of extension of the posterior capsular defect. And now you can see here, just see those three nuclear pieces which are lying on the hyaloid face. Hyaloid face is acting as a shield. So I'm taking hyaloid face to my advantage because of the low IOP, low fluidics, minimal turbulence, minimal infusion of fluid. So I can prevent the disruption of the hyaloid phase, and I will use hyaloid phase to my advantage, and you'll see that these nuclear pieces, they'll just float in the interior chamber, they won't go behind. So all these factors, as told by Dr. Rohit in his previous presentation, the prerequisites, good calibration, no leakages, you are able to complete even a hard cataract in a posterior polar cataract with a pre-existing. Always remember to inject viscoelastic before taking out the probe, and you'll see that these nuclear pieces, they'll just remain there. And I'll tell you, with just visco expression, you can see these pieces are out. So always remember not to overinflate the chamber with viscoelastic, because at times by overinflating you can lead to a disruption of hyaloid phase. So I'm doing dry aspiration. So this is irrigation, fixing, teasing, stripping, and aspiration of the cortex. So I'm not using any fluidics in this, and so this also prevents the disruption of the hyaloid phase. So as you can see, pre-existing defect which is visible now, and I am injecting the 3-piece IOL in the sulcus. The remaining nuclear piece which was lying there, that also came out.
Had the hyaloid phase been broken, I think it would have.
Yeah, and always remember to use triamcinolone, which confirmed absence of vitreous, and the case was completed. So just in a graphical animation, I would like to tell you, with low fluidics and following all the prerequisites, so these nuclear pieces, they just don't go back, and we use hyaloid phase as to our advantage. So
What are the limitations, in these patients, with the fluid vitreous? At times, I feel that this may not hold much
Yeah,
up.
that's also there. So especially in older patients, but this was a relatively young patient with an intact hyaloid phase.
Yeah.
But whenever you have a vitreous syneresis, then this won't work. Yes. So this was another case which I did few days back. This showed a moth-eaten appearance in the posterior capsule. We've been doing preoperative OCTs and all. So this, according to the Pujari et al., this is a short case of a pre-existing PCR. So what I do here is use all my prerequisites, do calibrated side ports, reduce my IOP to as low as possible, low aspiration, using oval rexes to my advantage, so that I can have the advantage of the small as well as the large arm rexes. And as this nucleus was little soft, I start with stop and chop technique, slow motion, low IOP 20, low aspiration flow rate, and then slow division. Luckily, the nuclear piece was not that soft. Otherwise, I would have done a layer by layer uh, emulsification. So now my plan is to take out the hemisphere, make sure that it is divided completely. Always remember not to rotate also. So I'm trying to take out the hemisphere without rotating it. You can do a back flip also, like just a flip on the back side and the nuclear piece just comes out without rotating. So this nuclear piece is
Can you explain about this backflip? Yeah.
so it's like just without rotating, what we do is we just flip the nuclear piece
I
with the
think this
second
is
hand
possible
instrument.
with an oval rexus
Yeah,
because
with an oval rexus because you have space in that subincisional area. So the other nuclear piece is also taken out and nuclear emulsification is continued. So I'm taking all the advantages of low IOP, minimal infusion of fluid, which prevents any undue deepening. Always remember to inject viscoelastic before taking out. Viscoexpression is done in this case. Slow viscoexpression, viscodissection is done. Viscodissection followed by high sleeve retraction of coaxial IA as previously discussed, which gives you a different level of plane of irrigation and aspiration. And what I did here was uh, there was a thick epinuclear sheet also which was giving me an advantage and providing a scaffold to the PCR. And once the epinuclear sheet was dislodged from all the ends, it is aspirated swiftly. So the good thing here was, you can see this PPCD defect which is published by Tetial. He showed that if you get this kind of disc defect, this confirms that it is not a pre-existing PCR. So luckily, it was not a pre-existing PCR, but it had a very high predisposition because of the
I think there's a plaque there.
yeah, so there's a plaque right in the center. So, so what do you do, Dr. Rohit? You often find thick plaques in PPCs. So
You know,
do you
there
try
are
taking it out or you just do YAG?
it depends. It depends. You know, if you want to put a premium IOL, and then you should at times try to avoid it because at times it just gives way if you try to aspirate and you have an uncontrolled extension. Second, if by any means your capsular axis size should be small because if it is small, if you even if you have a what do you call the giving away of the posterior capsule, at least you can put the lens in the sulcus. So and if by any means the patient is young and you feel that you would not be able to do YAG laser capsulotomy in this patient, in that case also you should try to avoid removing the plaque.
Yeah, because the PC is so thin in these cases.
Yeah, but I think this is a false positive
Yeah,
as far as
yeah.
because it was a moth-eaten type of.
Moth-eaten type, in the paper it showed it 100% pre-existing PCR, but there was a high predisposition definitely. So another last case which I would like to show is a PCR-induced iatrogenic cataract post anti-VEGF injection. So this was a 62-year-old patient, diabetic 15 years, history of VR surgery and repeated anti-VEGF injection. Visual acuity following last injection increased from 6 by 36 to 618 and then dropped to finger counting in 2 months' time. Slit lamp examination showed patient had developed cataract. Patient was keen on having femtosecond laser assisted cataract surgery. So this was a pre-existing defect that you can see in the pre-operative OCT. So my plan was to do flax. So what I do is I would make a 4.5 millimeter rexus, small rexus, so that I can do an optic capture later on and do femto delineation so that I can use epinucleus as a shield to the posterior capsular defect so that I can continue phacoemulsification without any worry. And then I'll use low IOP and slow motion phaco. So these were my phaco parameters. And I start my case. So calibrated incisions is one thing which we do. We usually make it with a 25 gauge needle. A small pinch in the center and the rexus is done. Slow motion phaco and slow division of nucleus. You can see that my IOP is low and advantages of this IOP is that there is less chances of pushing back of the nucleus. So slow division of the nucleus is done aim is not to rotate the nucleus at any point of time. Division should be done very slowly. So advantages are that, as I told you, the aim is to have a minimal pressure difference between the interior and posterior segment so that these nuclear pieces will just float in the interior chamber without pushing back. So there is no undue deepening of interior chamber, no posterior extension of the defect. Minimal infusion of fluid prevents any vitreous hydration or vitreous drawing to the tip. So what another thing we should keep in mind is that the ports of the probe, the irrigating ports, should not face towards the PC defect. So that is another thing, because if you do that, at times it can lead to vitreous hydration or hyaloid phase disruption as well. So I'm continuing phacoemulsification, and the advantage of femto delineation is that I have a good epinuclear sheet, a scaffold, which is providing a good shield to the posterior capsular defect, and it helps me continue phacoemulsification safely. You can see there is no peaking of the pupil, no drawing of vitreous to the tip as well, and it was a hyaloid. Hyaloid phase was intact. Inject viscoelastic before taking out the probe. So I'm injecting the viscoelastic. You can see the thick epinuclear sheet which is there. So I have taken the advantage of that. So now high sleeve retraction of coaxial IA is done to differentiate the level of irrigation and aspiration. What my aim here is to slowly dislodge the epinucleus from all the ends. So I'm taking out the epinucleus from all the ends and making sure that once all the the ends of the epinucleus are dislodged, then I should aspirate it swiftly so that there is minimal vitreous disturbance, anterior hyaloid phase is intact, minimal vitreous hydration. All these things helps in completing the case. The remaining and followed by a 3-piece IOL which is injected in the sulcus. You can see a pre-existing defect which is there behind, and as I had a small rhexis, 4.5 millimeter femtorhexis, so I did an optic capture.
I think with by reducing the IOP, yeah, this is obligatory. And as Dr. Mohan Rajan says, even God cannot see vitreous if you don't use Canacort for that matter.
Yeah.
What I feel is that when you are doing certain cases, you suddenly realize the moment you sculpt, it goes back. It has happened with me twice, thrice, or 4 times. I feel when you use this low IOP, you are practically negating this aspect where when you start sculpting and use with such great bottle height, with such great infusion pressure, with such great posterior bulging, if there is a predisposition or a pre-existing PCR, you end up with a situation wherein you suddenly find a nucleus drop. And then you think, what has happened? You feel, I have not done anything wrong. Well, we are oblivious of the fact that we are not using low fluidics, low IOP for that matter. Once you start using this low IOP, you create a situation wherein such certain accidents are not there. Dr. Chitra ma'am, I see you are there. In your institute, everybody is using low IOP. I feel this must have been a big boon because I learnt it from saw Dr. Ramamurthy use 20, and I gradually graduated by seeing him to move to 20. So this has become, history that suddenly you find once you start sculpting, the whole nucleus goes behind.
Ma'am, we cannot. There's a mic here, ma'am. So we've
This
been.
was, however, a case where there was only an injection done. So it could be a small PCR and could be a fibrous area also. Supposing it was a vitrectomized eyes, then it becomes even more challenging because the AC will deepen and there's
because
no
of the vitreous
posterior
cineresis.
support is not there.
Yeah.
So there are different challenges.
Yeah.
I enjoyed all of it. Only thing in that place, because the earlier case I felt that kind of PCR I would have put an IOL scaffold. By chance, the vitreous was formed, so nothing happened.
Yeah.
The earlier case. which
Yes,
you
sir.
showed.
Yes, ma'am.
Absolutely correct.
Very nicely shown.
Thank you. So we've been using low IOP regularly in all the cases because you never know when can you have a PCR, and this helps in preventing the nuclear pieces going behind. I think Dr. Rohit, you can.
So now we move on to another situation. Now what is this situation? That, can you put it on? Yeah. The case details are that the right eye has fibrotic cataract, left eye has pseudophakia with optic capture. So this means there was some PCR. So let's see how we do it. So what I did in this situation was we did flax, because in this fibrotic cataract we wanted to make a situation wherein we can have, complete the rexes. So the flag settings were used in these patients, and now what you will find, no, I think this has been, yeah. Let me go back again, yeah. So what you will find here is that the size of the rexes is small. So I have not shown how I completed the rexes, because that is beyond the scope of discussion for this course. So the capsular rexes was completed. Once the capsular rexes was completed, it was a hard cataract. I started with it, and I realized that while chopping, I had to use multi-level chopping in this patient. So I was aware of the fact that I might be landing up in a situation wherein this was done at 2x speed. And now when I'm totally separating it, I suddenly realize with this multi-level chopping that there was a PCR. So this PCR has happened now. So which was there and which could have been the cause in the second patient, in the second eye, where he had an optic capture, and this posterior capsule rupture shows that there was a pre-existing defect. So now what is the change in surgical plan?
Just wanted to add in fibrotic cataract is that by increasing the laser energy in femto and the incision depth, we can do a very good rexes in femto, because what it does is it cuts the capsule over the fibrotic bands. So capsule rexes is a very good in fibrotic in femto.
Absolutely correct. So what is the change in surgical plan? So we lower the IOP to physiological settings, no rotation, slow motion phacoemulsification, use IOL as a scaffold, supracapsular emulsification, do IOL capture, toric IOL, the patient wanted, we'll see whether we can put it or not. So the surgery is started. I just chop it, because I was using low IOP, different levels, total separation. There is no, we are repeating again and again, there is no high infusion pressure. The IOP is 20, the flow rate is 26. Just holding it, moving it up, doing it slow motion. I'm just trying, you will see that there is least amount of chatter because I'm doing it in a very slow, guided manner. And you will find with this low IOP, nothing is going behind. Now I find that I am caught on the wrong foot, because there is a capsule, open capsule behind, and how do I rotate it? Now can you see that there is slight, folds in the anterior, in the corneal side. This shows that it is not fully inflated. So now I am going to use one trick. Now what is this trick? I am going to rotate it in such a way that I am not going to push it behind. The moment I am able to go past it, I realize that it is still anterior to the posterior capsule break. Now I pull it forward, and then I would use IOL as a scaffold. I'll chop it so that it becomes smaller. And once it becomes smaller, that will be the time when I will use IOL as a scaffold. So I've just been able to separate it fully, and now I will use IOL as a scaffold. So this IOL as a scaffold is what Dr. Amar Agarwal has taught all over the world. It acts as a posterior capsule. Now with this IOL scaffold, you can work at a deeper plane because the artificial posterior capsule in the form of intraocular lens is there. Do slow motion. I'm not rushing into it because I'm just letting the nuclear fragments just stick on to the probe, stable chamber setting, and the case is completed. So this has already been taken up.
What are the chances of an anterior capsular tear in a fibrotic cataract?
It is less. It is definitely less as compared to an intumescent cataract or other cataracts. So because the fibrotic sheet doesn't easily extend on and become a wraparound tear. So now let's see another case scenario. So this is a pre-existing PCR in a posterior polar cataract, 32-year-old. Site of incision is there, is not in the plane, calibrated. This was a very early case, so I'm not using the calibrated side port incision which we use nowadays. This is an oval rhexis as has been greatly propagated by our own Dr. Kiranjeet Singh from Amritsar. So this gives the advantage as has already been explained by Dr. Tushe. Now once that is done, we are, inside out could have been done, but that can cause inadvertent, posterior capsule and a nucleus drop also. Large rhexis gives the advantage. All these advantages have already been told by Dr. Tushe. The smaller, arm provides easy optic capture, nucleus piece retention in the bag, and tamponading. So I am doing the technique which Dr. Vajpayee propagated. It is layer by layer separation. This is risky. You have to be fully adept in using this technique, and you have to get used to it in your normal practice when you come across patients wherein they have soft cataracts. Because if you will not know how to do it, you can create a situation where it can cause sudden hydrodissection and a blowout. So I am doing it at different planes and at different places so that I am able to create 3 or 4 layers so that I have a shield. I do not have, direct contact whatsoever with the posterior capsule. This is an early video. You will find that the IOP I'm using is 42. So the first thing is that I have taken out the inner core. So by just repositioning of the inner core, it is coming out. Now the posterior capsule at this point of time is not exposed because of the epinuclear shield. So this is all what I'm doing. I'm taking it out slowly, layer by layer. Just see the CDE. The CDE is 0. At this point of time, I have taken out 2 layers. The third layer, I'm trying to take it out by just phacoaspiration. Lately, what I have started doing is, now this is the escape route which Bob Osher always says, which you should use. And this escape route has been done so that there is no build-up of everything. Now, still at that point of time, there is no exposure of fluidics. I could have done viscose separation also and pulled it out, but I, at this point of time, decided to use epinucleus as a shield. Now, how do we use epinucleus as a shield? I dislodge it from all the sides and do not aspirate it. And when I am not aspirating it, I am not exposing the fluidics to that an extent so that the vitreous doesn't hydrate and doesn't come out. So the IOP is okay, it's not that low. Ideally, it should have been much lower. I'm trying to dislodge, but till the time I totally dislodge, I am not going to aspirate it. The fluidics, the epinucleus shield is still protecting the posterior capsule. I'm taking my time, I'm not rushing as and how I'm going around, and this is the last the cortex remina and the epinucleus which needs to be dislodged. And once it is dislodged, it is done. You will find which one point which I forgot to tell is the retraction. So this retraction is done so that it mimics a bimanual. But a bimanual can also be tried. With this retracting, I have been able to separate the level of irrigation and aspiration. Stable chamber settings are being used. Now the next point is that I'm going to round off the capsular axis, not the capsular axis, the posterior capsule which has gone to the periphery. I found that there was an edge. Now the click in doing posterior capsular axis in these patients is that you have to have stable chamber settings. Go through the what do you call side port. Do not overinflate the bag. Make the capsule slightly concave and then go ahead. And you will find that I was able to round it off. Once I'll again inflate slightly and push it back, and now I've been able to round off this capsular tag and made it a sort of a posterior capsule. Now I am going through the other incision which I have created with Haldi Purkar's capsular axis forceps, and I've been able to round it off. I was not confident of, now the triamcinolone is being used, and you will find that there is no disturbance of the anterior hyaloid phase. A 3-piece multi-piece is being injected. This was much before the old movie of concept of reverse optic capture. So I'll use the short arm of the oval rexis and do an optic capture. So here you will find that the optic capture has been done, and the patient is well done. So this is another movie which I want to show. This patient has a pre-existing PCR, a 41-year-old lady, bilateral posterior polar cataracts, high expectations, moth-eaten appearance which shows that the posterior capsule is not intact. By all means, the capsular axis which I am going to try, I do not over-inflate the chamber, that is the first thing. Calibrated side port incision so that we have adequate stability in the chamber. Again, an oval rexis. This has become a thing which we do in all our posterior polar cataracts. I am caught on the wrong foot because here I find I am in a situation where I will not be able to divide it fully because it turned out to be softer than what I had expected it to be. So I'm trying to divide it. I'm not able to divide it. I try cross-chopping as has been advocated by Ronald Dior. So I just trying to debulk it. When I'm trying to debulk it, I want to debulk it opposite to where my incision is so that there is an escape route. Now what I'm doing is I'm doing centripetal mechanical dissociation of the inner nuclear core. So it has to be done in a slow motion manner. You do not have to rush. So now I'm just doing it, repeating it, and I feel that I may not be able to complete it. The IOP is hovering around 24, stable chamber settings. Now what is the next thing which I'm going to do? The next thing which I'm going to do is I'm going to do viscose separation. So from both sides, and I'll do sub-incisional viscose separation too. So now what that has been done. Now with this viscose separation done, so I have created a place. Now I'm trying to mechanically dissociate. I've further reduced the IOP to 20, which makes it, there is no chance of, anterior hyaloid phase getting broken, no chance of vitreous getting hydrated. The nuclear fragments are floating, no posterior bulging. All these things are concurrently happening, and I'm mechanically repositioning the nuclear fragments in such a way that I'm able to free it up. Once I'm able to free it up, I'll emulsify it with the nucleus not being pushed behind, just floating in the anterior chamber. The click in the story is stable chamber settings, low IOP, low fluidics, whatsoever. Once that is done, again stable chamber settings. Now I would like you to see another thing which I usually do. You could have easily done a bimanual. You irrigation, aspiration, this is the Gills-Welch technique, dry aspiration, fixing, teasing and stripping. You do not have to aspirate because if you will aspirate into the cannula, that will cause chamber collapse. So you just have to strip it and move towards that. You will find that the whole mass has collected and now I am just visco expressing the cortex out, and the Canacort is being used, shows the absence of vitreous and the anterior hyaloid phase is intact. The intraocular lens, I'm putting in a 3-piece intraocular lens using the shorter arm to create IOL capture. IOL has been well captured. Now with this you will find again triamcinolone being injected and you will realize that there is no vitreous. So in a patient who had an open capsule, the patient's vision, you will see how perfectly it is centered. That is day one. Vision was 20/20 with minus 0.25 and minus 0.25 because the IOL was brought slightly forward. So this is another case scenario wherein posterior rhexis is being done. So again what I am trying to put across in these patients is what you have to realize is that you have to use higher magnification. You have not to, you have to focus it well. There was some difference in my focusing and the focusing in the camera, and you have to go, because posterior capsular rhexis, if done in the right way, is very easy. It's the initial hiccup which we have. Stable chamber settings, posterior capsule not that deep, because if it will be deep enough, you will create a situation where you will find it difficult to hold. And the second part is that the chamber settings should be there. So I always use micro forceps through a calibrated incision so that there is no undue efflux, no undue instability or unstability of the chamber, and you will find that the capsular rhexis has been adequately posterior completed. So this is how you can complete it at times. This is another patient where you will find that there's a pre-existing PCR in this patient. I'm doing this, again, what do you call, dry aspiration. So I wanted to show you another one. Yeah, this is the one. This is the video wherein, I'm doing dry aspiration, but the posterior there is some bit of vitreous in the anterior chamber. So what I am going to do now is, I am going to use the cut eye mode with maximum, cut speed, whichever your machine has. And once the vitreous has been cleared, then you can go into the IA cut mode and take out the whole amount of, cortex which is lying with an open posterior capsule. So this is something which all machines, I suppose, have. First, you have to clear up the vitreous by going into the cut IA mode, and once you are done with it, then you can use the IA cut mode.
And low fluidics.
Low fluidics is very important for that matter. This is another patient wherein there was a posterior capsular tear, was not, the posterior polar cataract it was. The surgery continued, and you will find that everything is going on well. So I'm trying to implant the IOL. That is also going on well. And once the IOL is implanted, the next step was to just push it slightly without putting stress to the posterior capsule. And while doing, removing the visco, inadvertently, you just see what I did. I just pushed it slightly, and the moment I'll push it more than what is required, the posterior capsule will give way. So you will find now that there is an open posterior capsule. I did not touch it because everything was well centered and I just took it out. So all is not over till it is over. Thank you very much for your kind attention. We can take up questions, whichever we have, because we have 5 minutes with us. Yeah.
Sir, nice course. Sir, I want to put once we have, during crunching, we have a PCR or this, then once we take the pieces into the supracapsular, we should not sub-chop them.
Yeah. This is what the concept is.
Sub-chopping makes it possible that pieces can go behind the, through the rent, and so the sub-chopping should be avoided. Number second, I want to tell ki once you have a PCR and then you, instead of, for the general masses or in general, instead of a coaxial IA, we should use a bimanual IA. That's preferable.
I think it was a very relevant and a very good question. I have already, coming to the second part, first part, you know, basically, when we are using low fluidics, as we have shown, we have transformed the foe, which is the open posterior capsule and the anterior hyaloid phase, from a foe to an LI. If you are not following all the principles which we have shown of using low IOP, wherein we are not putting pressure, wherein there is no posterior bulging, wherein there is less chance of vitreous getting hydrated because of low fluidics, you can very well try to do it. Initially, you may not, but you know, graduating into low IOP is something which has to be graduated over the time. As far as your second part of the question is concerned, that was using bimanual. As we have already said, bimanual is the first choice. As Dr. Tushe said, if you have not calibrated it, at times with the unstable chamber, you can create a situation. What we do in our practice, we separate the level of irrigation and aspiration by retracting the sleeve. That is a partial way of doing it. But if you have a calibrated, you know, all your incisions, you know, a bimanual is definitely a much better option. But the way out with a coaxial is that you retract the sleeve. Anything you would
Definitely. So, Dr. Rohit, how do young surgeons graduate to a low IOP?
Yeah, that's a very interesting question. You know, if you are using 60, you should not suddenly come down to 20. You have to gradually graduate it. 60, make it 50. You know, you have to see when you place the phaco tip in the center, whether the chamber is collapsing or not. And then you can, you know, titrate it. If you are having a hard cataract, you can increase the vacuum but decrease the flow rate. But if you have a soft cataract, you can do the other way around. And as and how you move, you can gradually graduate from using high IOP to a low IOP. I tell you, this low IOP emulsification has changed the life of all of our patients also and ours also, because the patients usually do not feel pain. It's a painless procedure. We want it. I do not have any financial interest whatsoever. But what I realize is that with low IOP, you get a buffer wherein you get a breathing space if you have complications. So graduating to low IOP has to be done in a gradual phased manner.
Great. Thank you.
I think I would like to thank each one of you who took time to be here in this course. I hope this course would have made a difference, and I hope you can, when you go back, you can add a few things into your practice. Thank you again for being here.
Thank you so much.